Hi Akshay. Hey Akshay. Hi Akshay, can you hear me?
Hi, Orgo. Hi. Sorry. I didn't realize I was mute. Just give me one moment. I think both the volunteers have joined, but they have not joined as panelists. So I'm just going to, I can see Mehak here. So I'm just going to promote them to panelists and then we can start. That's Mehak and the Nupur, right? So Nupur.
So we've joined from the same system. Hello.
Okay, so have you been able to be, so both of you are logged in then, right?
Yes, so
Be
yes.
able to, okay, great, perfect. Okay, perfect. So then, great. So I think then we are set. So let me just introduce you, Orgo, and then we can start the show. Yeah. Hello everyone, this is Akshay Baiti and welcome to today's webinar. And I'm so glad to have Dr. Orgo Chatterjee with us. Orgo is, I think, one of the most intellectual and cerebral radiologists we have in India today. He's from TMC Kolkata and does head, neck, and abdominal onco imaging with a special interest in hepatobiliary and GU oncoradiology. Today is going to take this interactive session based on mixed bag abdominal cases. And to take the cases, we have with us two volunteers from Sion Hospital, Mehak and Nupur. Thank you so much for volunteering for this, Mehak and Nupur. Argo, you can share your slides.
Yeah, sure. All right. Very good evening to all of you. So the slides are visible, right? Nupur, Mahek, you can see my slides?
Yes, sir.
Okay. So let us start with a very mixed bag of cases. So this is our first case. We are looking at a 33-year-old man who has leukemia and fever under investigation. Okay, so we ran some ultrasound which showed something in the liver and we did a CT. So who take this up? Mahek or Nupur, who take this up? Mahek, you can start maybe.
Okay, yes, sir. Um, there are multiple well-defined lobulated heterogeneously enhancing lesions with enhancing septae within, um, noted scattered in bilateral lobes of liver. The largest lesion seen in segment 8.
Okay.
Also, there are some GB calculus.
Right.
Um, there is splenomegaly, and
Right.
there is also a well-defined hypodense, I suppose, enhancing lesions in sub-centimeter size enhancing lesions in splenic parenchyma.
Right.
Um,
All right. You said that this is a lobulated, heterogeneously enhancing multiple lesions in liver parenchyma,
hmm,
and there are enhancing septations. So
hmm.
I zoomed the largest lesion for you. Would you add a little bit here? Is there anything the more that you can see in the zoomed image? I would rather say there is a. Can you see my cursor?
Yes, sir.
Yeah, so I'd rather say you can see a faint. First of all, the liver adjacent to it shows a little bit of a hypo enhancement,
Hmm,
something like a segmental hypo enhancement. And
hmm,
if we are really looking with imagination, we can see a rim around the entire lesion.
hmm.
So it's more of a rim, and there
Yes.
is a very thin hypo rim around the lesion as well. Now, we also have splenomegaly and we have some lesions in the spleen.
Hmm.
So, what do you think? What can be your differential and what would you do next?
Um, in the according to the history given, a patient has having B cell ALL, so these could be lymphoma deposits, lymphomatous deposits.
Okay.
Also, another differential could be multilocular echinococosis.
How do you explain the spleen and this part of the country very rare? In fact, some patients do come from northwest frontier and especially places like Afghanistan in Delhi colleges, and they do see multilocularis. We don't really see multilocularis, and definitely not in Kolkata. And then how do you explain the splenic lesions?
No.
Yeah, so that can be a differential.
Hmm.
I mean, simply by the appearance. And you also said it can be lymphoma. So what
Hmm.
would you do next?
Um, a
This patient had leukemia. We know that.
biopsy or a PET scan.
Okay. Here is your PET scan.
Hmm. So
Did
hmm,
this. So do you want to add something?
and these are PET avid lesions.
Yes.
The splenic lesions doesn't show uptake.
I would say splenic lesions are too small to show uptake.
Hmm. Hmm.
And do you think it can be multilocularis now?
No.
So your differential is lymphoma, right?
Lymphoma, yes, sir.
Okay. This is the CT 6 months back. Do you see something? I'll show you. It's maybe hard to see on screen.
Hmm.
There is a tiny lesion here.
Hmm.
So your idea of lymphoma still holds, right? Because you'll say this was a leukemic deposit and which grew.
Hmm.
What I would like to point out is you said that this looks like something that has septa inside it and that is enhancing.
Hmm.
So I would rather say it's a multiloculateral lesion, which is correct. And I also thought there is a rim that I can see,
Hmm.
and there is another hypotenuse rim around, which kind of gives me some. I am a little worried about kind of some infective pathology. But this lesion was present there since 6 months back. My question is, you will still do a biopsy to prove, right?
Hmm. Yes, sir.
Yeah. So would you send this biopsy only on formalin or will you send a saline sample?
Saline sample also to rule out infectious etiology.
Yeah. So that was the whole point of this. This was hepatic macronodular tuberculosis. It is very difficult for you to diagnose this on CT. What the important point in this case is that you suspect that it may be potentially infective, and considering it was also present 6 months back, maybe a granulomatous inflammation. So I'll probably send for TB and fungal, which we did thankfully, and TB came. So micronodular tuberculosis is actually far more common, something that you are seeing in the spleen. This kind of macronodular appearance is very rare. in this type of cases, interestingly, evidence of tuberculosis may not be present elsewhere in the body. So you may see a normal lung X-ray. You may not see anything in the GI. Differentials will always be metastasis, abscess, and a primary malignancy. Metastasis includes lymphoma, leukemia deposits. So important thing is included a biopsy sample in saline if infection is remotely suspected, because otherwise you will have to repeat the biopsy. Okay.
Yes, sir.
Okay, so this is a 21-year-old man with DLBCL, which is lymphoma, non-Hodgkin, again with fever under investigation. So maybe Nupur can take this up.
Yes, sir. So there are multiple lymph nodes, there are multiple pre-aortic, para-aortic, and mesenteric lymph nodes noted, which are homogeneously enhancing. There's a large hypodense, non-enhancing, well-defined lesion noted in the spleen, the inferior pole of the spleen.
I have actually given you the coronal. Will you say one lesion, more lesions?
Sorry, sir?
Will you say there is only one lesion in spleen or
No,
more?
two lesions. Two lesions.
Two lesions.
Yes, sir.
Yeah.
Hypodense. And no obvious compression of the vessels are noted in the given sections by the.
That's very good. Yeah.
And the splenic lesion is seen invading the chest wall laterally.
Very good. Excellent. Excellent. So the splenic lesion is invading the chest wall, right?
Yes, sir.
So what do you think? You do realize that this case is for the splenic lesion because the lymph nodes can be explained by lymphoma.
Yes, sir.
So what do you think that is?
So it could be splenic, it could be of infective etiology or deposits of the lymphoma in the spleen. And,
can this be splenic infarct?
So it's extending into the chest wall. So
yeah, so that is not an infarct.
Not an infarct.
We see this is going beyond the spleen.
Beyond the spleen, yes, sir.
Yes. And infarct classically described to be a wedge-shaped lesion. And we know the capsular enhancement is often persistent.
Yes.
The capsule is not seen here. Right. So what else? So you said lymphoma and infective. Any pointers towards infection? Do you want to say what kind of infection? Is it an abscess? Because if it's an abscess, you have to aspirate it and send the pus and then also potentially drain it. If it's not an abscess, then no, we don't need to do that. Something that is very worrisome or something. So what will you do next? Okay, let me ask this question. So you said that this can be lymphoma versus infection. And this patient had fever. The clinician is definitely suspecting infection. So what would you do next?
So it is.
I'll give you a closer look of the lesion. As you said, that it is going beyond the spleen and involving the chest wall, right? It's much better seen in these oblique axial images. There is a little bit of pleural effusion too, but that can be reactionary. So what would you do next?
So we'll do a biopsy.
And what do you expect when you do the biopsy? Send for what? These are the real life questions that you will get asked. That what would you send? What are the tests that you do send for?
We'll send it for culture and
TB culture, fungal culture. or just bacterial culture?
So TB culture and fungal culture.
Okay, so I will just go on with this case. So what you see here is, as you can see that this lesion, as if it does not care whether it's spleen or chest wall or rib or diaphragm, it does not care. It is just sitting there.
Yes, sir.
Isn't it? It feels like that there is a blotch of lesions just sitting there. The lesion does not care whether it is invading the splenic capsule, then it is actually invading the diaphragm, then going into the the thoracic musculature. It does not care. It's just there. It just went there. So this kind of invasion in this kind of patients, immunocompromised patients, or patient is diabetic, always raise the possibility of mucor.
Mucor.
Because why mucor is important? First of all, mucor is a fungus that is not covered by normal antifungal coverage that is given to hematology patients. Mucor often needs surgical debridement. So if you see mucor, especially common in sinonasal region, and this is one of the emergencies in sinonasal imaging, that if you see mucor and if you think this is mucor, you ideally should ring up the physician and tell that this patient probably has mucor, because this often needs surgical debridement. This patient actually went directly for splenectomy because we said this looks like mucor.
Yes.
So remember, visceral mucormycosis is possible. Lung is commonly described. Sinonasal is common. We have all seen cases, but it can also happen in spleen, kidney. We have seen kidney cases. So it is seen in diabetic and immunocompromised, not seen in immunocompetent patients. A very high degree of suspicion is necessary. Surgery is often needed, and it may simulate and or associate with infarcts because it involves the vessels. Yes. So it may simulate infarcts. It may look like infarcts, especially in brain. It may look like infarcts. So you have to pay attention, really pay attention whether this is infarct or fungal lesion. And lack of respect to tissue plates should be a red alert. It will look like a blotch, as if it does not respect any tissue plane. It is just sitting there as a blotch. I often tell to my fellows that it looks like an artifact, as if it is just sitting there. Every other pathology gets a little altered by tissue planes. Mucor does not get altered by tissue planes. It just stays there. Okay?
Yes, sir.
Okay, so the next is a 75-year-old man undergoing staging CT for esophageal mass. So this is a staging CT. Okay, so what do you see here? We do stage the abdomen in esophagus. So we were looking at the abdomen and this is what we saw. So maybe Mahek?
There is increased perirenal space with lipomatosis seen, and in between fat stranding is seen. So this is perirenal lipomatosis.
How are you so sure? This is not liposarcoma. I see so many soft tissue. I see soft tissue here. I see soft tissue here. How do you know this is lipomatosis and not liposarcoma?
It is bilateral and it can be, so it can
Yeah,
be
so that's the
also.
that's the answer. That's the correct answer actually.
Yes, sir.
It is bilateral.
Yes.
We definitely it is bilateral, looks symmetrical. It is causing some distortion in the renal parenchyma. So we are thinking about lipomatosis, but we cannot be sure. It
Yes.
does not look like one mass. It looks like two masses. So it's very unusual for a liposarcoma to be like that. So we were not sure. So we actually ended up biopsying this and we targeted those soft tissue areas, nothing came out. Then we stuck to our diagnosis of lipomatosis and the esophagus treatment went on. And this is the CT we have recently repeated. In fact, this CT was done yesterday, and his lesions are lipomatosis is exactly the same. It has not changed, maybe a little bit more distortion of kidney shape. So this was lipomatosis, as you have correctly pointed out. My question is, what are the other possibilities? Liposarcoma 1, what else? So there is another entity we used to see in old times, we used to see in AIDS patients, which is lipodystrophy. It happened with ART. We don't see it anymore. I'm not really sure how common it is now, but we used to see that. So remember, there is another entity called renal replacement lipomatosis, which is usually associated with calculus disease, and the kidney gets replaced by fat. Here the kidneys are intact. These are often unilateral. So differentiating with liposarcoma is very difficult, and often patients end up getting a surgery. A big renal angiomyolipoma may also simulate this, and lipodystrophy, which was common with AIDS patients with ART. Now I don't see those cases, but I'm now in cancer hospital, so I'm not really sure they are coming to me. But we used to see that with AIDS patients. So this is a companion case. Do you want to say what this is? This is T2 axial, T2 coronal. This is Vive pre-contrast, post-contrast.
A renal hilar lipoma?
This is pelvic lipomatosis. So
Pelvic.
what you saw, it is the same thing. It is just much less severe, and it's just the renal pelvis. This is actually more commonly seen in elderly diabetics. Often you will see this kind of renal lipomatosis in hilum. Often bilateral, can be unilateral. So this is renal pelvic lipomatosis. Okay.
Yes, sir.
Okay, 75-year-old man with right flank pain. Nupur?
Yes, sir.
So what do you think? I will tell you the phases. This is a corticomedullary phase. This is the nephrographic phase. These are axial. This is corticomedullary phase, coronal, different sections, same phase. This is the excretory phase of the right kidney, excretory phase of the left kidney.
Yes, sir. There are multiple hypodense lesions noted in bilateral kidneys with loss of the normal, with non-enhancing lesions in bilateral kidneys.
Okay.
And there is a scarring of the bilateral renal cortices.
Okay. Go one by one. Okay. You said the lesions are bilateral.
Yes, sir.
And you said bilateral cortical scarring is noted.
Yes,
Okay.
sir.
Then go on. What else do you see? You said there are lesions that are bilateral.
Yes.
So describe the lesions. That this lesion is seen in this region, then this is how it is behaving.
Okay, on the right side at the upper pole, there's a heterogeneously hypoechoic lesion.
Hypo-enhancing.
Sorry, hypoenhancing, hypodense lesion noted at the upper pole of the right kidney. Then at the mid pole of the left kidney, there's another similar morphology lesion with few hypodense areas within.
Okay.
Another lesion at the lower pole of the right kidney. is noted.
That's just the scar. That's okay.
Yes, sir.
Two main lesions I can see. Okay,
Yes.
and in the excretory phase, anything?
Mm. So the excretion looks normal. However, the even on the delayed phases, it does not show any enhancement.
What
And
does not show enhancement?
the lesions do not
Okay.
even on the.
So what do you think this is?
Sir, tuberculosis.
Why tuberculosis?
So there's a so there's a phantom calyx
Where?
on the at the upper pole of the left kidney.
No. Left kidney. This one is left. This one is right. This one is right. This one is left. Right kidney, left kidney. So match this with this. And match this with this. I wish you had a marker. Can you use a marker? I think you can, na? Okay, I will show you. Okay, so the thing about, so you think this is tuberculosis?
Yes, sir.
Okay, so how do you prove it?
It's a biopsy. And also
Is it because I am
culture
showing
of
all
the
tuberculosis cases?
culture of
Urine culture
urine
sensitivity
culture.
will
Yes,
be,
sir.
yeah, so often urine culture sensitivity is negative in TB and it is very hard to prove.
Yes, sir.
Of sometimes it is, we have to resort to biopsy. Okay, so I'll show you. First of all, what I see is it's bilateral scarred kidneys.
Yes, sir.
Second, I see a lesion here in the upper pole of right kidney, and I clearly see a wedge-shaped area of hypoenhancement. Another more or less wedge-shaped area of hypoenhancement is seen in upper pole of left kidney and this one, this interpolar region of left kidney. Additionally, what do I see? I see a multiloculated, poorly defined nodule with some septal enhancement. And there is another low attenuation, non-enhancing area here in the left kidney as well. Additionally, what do I see? Do you see this one, this Y-shaped structure? Yes.
Yes, sir.
So this is your phantom calyx. This is a calyx that is enhancing, wall is thickened, and you do not see that calyx getting opacified here. The middle calyx is getting opacified, the lower calyx is getting opacified. You do see some infundibular stenosis. Here also there is this is harder to see, but here we can see the infundibular stenosis. So whenever, the point of this case is, whenever you think you are looking at pyelonephritis, whenever you see wedge-shaped hypoenhancing area in kidney, you have to think about pyelonephritis and infarct. In infarct, as I said, some degree of some degree of capsular enhancement will be preserved, and there will be sharply wedge-shaped, and pyelonephritis will not have that capsular enhancement, may be associated with hydronephrosis or calculus, but that is normal bacterial pyelonephritis.
Yes.
When you see bilateral pyelonephritis in a diabetic man, elderly, you have to pay attention to other things. Look at the calyces, look at the excretory phase. Is there a phantom calyx? Is there infundibular stenosis? Is there an area where do I think the calyx look normal? So I know IVU is no longer done, but this used to be findings of IVU in tuberculosis. So yes, your diagnosis is correct. This is renal tuberculosis. It may simulate tumor, which is called a pseudotumoral type of tuberculosis, as you saw as here. If somebody just shows you this, you might think this is a lesion, neoplastic. Always look at the excretory phase, irregular calyx, papillary necrosis, phantom calyx, or infundibular stenosis. These are important, and remember, it is often culture negative. So even if you say tuberculosis, the culture may still not show tuberculosis. And this is another example. You can see there is significant calyceal wall enhancement, and you can see this is phantom calyx. This calyx, these are not getting opacified. So this is typical of tuberculosis. So keep this kind of appearance in mind.
Yes.
Okay. 31-year-old lady with multiple liver masses. Out from outside, the diagnosis was square cholangiocarcinoma. Okay. Who's gonna take this up? So these are basically all portal venous phase CT. These are axial and these are coronals. Same phase, just different sections. Nupur.
Sir, I'll take the case. Mehak, sir.
Okay.
So there are multiple ill-defined, fairly well-defined lesions noted in bilateral lobes of liver. They show heterogeneous enhancement. Also, there is another heterogeneously enhancing hypodense lesion noted in
Which one are you talking about? This is left lobe.
segment 2 and 3.
Okay, yeah. Segment 2 and 3. Okay.
Also, there are multiple lymph nodes seen in para-aortic region, sub-centimeter size lymph node seen.
Okay, if they are sub-centimeter size, they are not significant, no? Liver is enlarged a little bit?
Yes, liver is enlarged.
Yes.
The lesion doesn't show any capsular retraction or IHBRD or delayed phase enhancement, persistent enhancement.
Okay, so I will just walk you through certain findings. So this is a multiloculated lesion with some wall enhancement and some septa, kind of looking like that tuberculosis case I shown you now. This looks like a multiloculated. Okay, that's fine. What is
Yes.
that? Look at this. Can you see a line here? Can you see some lines here, serpiginous lines like this? See, this is a line.
Yes, sir. Yes, sir.
Can you make out some lines? See here, lines. What are these things? Looks very peculiar, right?
Uh, uh, worm-like lines.
Yes, worm-like lines. Here to see a line. Many lines. And then there is a big abscess like. Does it look like cholangiocarcinoma?
No, sir.
No.
Seems
So
like
what does it look like?
infective etiology like
What infection?
melioidosis.
Ooh. Have you seen cases of melioidosis? It's a very good diagnosis, actually. Have you seen melioidosis in your institute?
Sir, I've not seen in my institute, but I've seen in textbooks, sir.
Okay. So the left lobe lesion looks like melioidosis. Absolutely
These
possible.
the serpiginous line looks like worms. Could be visceral larva migrants.
Visceral larva migrants. Yes, that's a good answer. So I am just showing you that there are tracts. So visceral larva migrants definitely is a good answer. There is something. So I will show you. Can you tell me what kind of images these are? Same coronals. This is minimum intensity projection.
MIP images.
You
Yes.
can, these are MINIPs, not MIPs, MINIPs. So minimum intensity projection, so you can see the low density structures much better. This is good for bile ducts. In liver, when you have multi-detector CT, do this for bile ducts. So what you can see is, you can see the entire tract. See how the tracts are coming serpiginous, and so they are coming from capsule to the portal tract. So this is a bile duct. Again, some serpiginous tracts. You can see the huge serpiginous tract here, and they are coming towards the center of the liver, the bile ducts. So this is a pathway taken by fasciola hepatica. They go out from the duodenum, roam around in peritoneum, pierce the liver capsule, and enter the liver. Okay. So
Yes.
visceral larva migrants is also a possibility, but they do not show this degree of serpiginous tract, but it can be a possibility. But you have to raise the possibility here is that I am looking at an infection and possibly a parasitic infection. Yes?
Yes, sir.
Yeah, so that's important. So you have to say that I am probably looking at a parasitic infection, can be fasciola, can be visceral larva migrants. I'm not really sure. Any blood test that you will look at just quickly, something that will be available very easily with the patient.
IG levels.
That will not be, unless and until you tell them, they will not do this. Huh? Something that is already available with the patient, usually.
CBC.
Yes. So what will be there?
Eosinophilia.
Yes, there will be high eosinophil count. So look at this. This patient had a eosinophil percentage of 14%. So this was fasciola, liver fluke. First of all, this is far more common than you think. So you will see many serpiginous calcification in liver. Do you remember seeing those? Serpiginous calcifications in liver. Pay attention next time you
Yes.
report CTs, you will see one or two.
Yes.
So those are all healed tracts. So they are pretty common. There are publications from India of large case series. So you will see them. If you know how to pick them up, you will see them. So the capsule to portal tract tunnels, you will see, and you will see subportal, subcapsular or periportal bunch of abscesses, which you can also see in melioidosis. High eosinophil count in active disease can be a pointer. And remember, it is very difficult to demonstrate in bile culture. So they may still disagree with you. They will say, this is not infection, nothing came in. But you have to insist that this is parasitic infection and not some tumor. Okay.
Yes.
And just a companion case. What do you think this is? I'll not give you history. This is T2, contrast, MRCP, coronal contrast, delayed phase.
There is a lesion which is causing IHBRD.
Where is the lesion?
segment 7.
Yes. So this is the lesion
Hmm.
that is showing peripheral heterogeneous enhancement. Difficult to say because I don't have any other phases. And you can see this is causing IHBR dilatation and
This,
atrophy of the segment 7, possibly also 6.
Hmm.
And also this is the left portal vein, main portal vein. Where is the right portal vein?
encased.
Encased and attenuated, right? And this MRCP shows that there is a what type of block?
Uh, there is a hilar block.
Do you know the classification of hilar blocks?
So
Yes. When there is hilar block, either it can go to the right side or it
Or
can go to the left side, right? When it goes to either side, right side 3A, left side 3B, both side 4. This is the type 3A block I can see. The left ducts are actually normal. The right ducts are separated. Okay. So this is actually a
cholangiocarcinoma.
So this is a cholangiocarcinoma.
Hmm.
Okay. Okay. Incidental finding. This is very quickly. You will not be able to find out otherwise. This is an ovarian cancer patient. We found it incidentally. It's just a nice case. I just wanted to show you. Uh, so this lesion is the question. This lesion. This lesion. This.
Pancreatic tissue.
Yes, very good. So this is the right pancreas. This is the actual pancreas. This looks absolutely like pancreas. So ectopic pancreases are often seen. Remember, ectopic pancreases will be connected to some kind of bowel loop. So this is actually connected to jejunum. This is the tissue. You can see a tiny duct here. Tiny duct that is going to the jejunum. So ectopic tissues are often seen. They can simulate tumor. If you are not careful, you will say this is a carcinoid. Yes, because it is enhancing really well. Okay.
Yes.
Okay. So this is a patient with chronic hepatitis B. Somebody detected a nodule in ultrasound. This is MRI. T2, diffusion, pre-contrast, arterial phase, venous phase, hepatobiliary phase. We have used gadobenate. Do you use gadobenate in your institute?
Yes, sir.
Okay, so that is a hepatobiliary phase using gadobenate. So what do you think?
So there is a T2 hyperintense, isointense to hyperintense lesion noted in the right lobe of liver, which is showing diffusion restriction. Which is showing diffusion restriction. Showing diffusion restriction, and on post contrast images, it shows peripheral enhancement and a delayed enhancement of a solid component within.
Hold on. This is the arterial phase.
Yes, sir.
Do you think there is peripheral enhancement?
So
By
on the
peripheral, you mean a rim enhancement?
rim enhancement. Yes, sir.
I'm not really sure I see a rim. Do you
On
see
the
a rim?
venous, on the venous phase, sir.
No. You have to talk about the enhancement in the venous phase. Okay, so you say there is a rim enhancement in the venous phase.
Yes, sir.
Yes, and then?
And a delayed enhancement of a nodular component, solid component within.
Where? Here?
Yes, sir, in the delayed.
So that's the hepatobiliary phase. That's not the delayed phase.
Hepatobiliary phase, yes.
Delayed phase means there is still contrast in the vessels.
Vein. Yes.
There is no contrast in the vessels. See, the portal vein is empty.
Yes, sir.
So this is a hepatobiliary phase. Okay?
Yes, sir.
So what do you think this is?
So hepatic adenoma.
Achha. Why do you say this is hepatic adenoma?
So because
I would also like you to focus on the history once more. Patient with chronic hepatitis B nodule detected in screening ultrasound.
Nodule and so hepatocellular carcinoma.
Okay, why did you change your diagnosis?
Nodule and nodule appearance.
No, nodule detected in ultrasound, not nodule in nodule. Where is the nodule in nodule appearance?
So arterial phase.
You think this is a nodule, inside there is another nodule.
Yes, sir.
This one.
Yes, sir.
Yeah, so what you say hepatocellular carcinoma, would you give a Lyrad's category?
Yes, sir. Five.
So would you biopsy?
No, sir.
Yes. So I will correct you a little bit. So this is a, first of all, whenever we are looking at chronic hepatitis B patients, we know this is a at-risk liver. That means Lyrads now comes into play. Okay. So the patient is at risk of HCC. That's why the patient was getting the screening ultrasound.
Yes, sir.
So I am now seeing a T2 intermediate heterogeneous nodule in the segment 588, which is restricting in diffusion.
Yes, sir.
In T1, I see central internal T1 hyperintense to isointense areas. There is a nodular arterial phase, non-rim arterial phase hyperenhancement inside the nodule. May not be the entire nodule, but this is not a rim.
Yes, sir.
So the enhancement, rim enhancement or non-rim enhancement in case of a patient who has at-risk liver, that means at risk of HCC, the rim or non-rim enhancement will be described in the arterial phase or late arterial phase to be precise. This is a capsular enhancement. This is not a rim enhancement. This lesion has already washed out. So there is venous wash out along with capsular enhancement. And in hepatobiliary phase, most of the lesion has washed out. I mean, it's not a washout. Most of the lesion shows no retention of hepatobiliary contrast. A little bit of the lesion shows hepatobiliary contrast retention.
Yes, sir.
So this will be Lyrad's 5 because there is arterial phase non-rim hyperenhancement, washout, capsular enhancement, and you add, this is already Lyrad's 5, but there are other features like T2 intermediate signal, diffusion restriction, nodule in nodule appearance, this kind of things. Okay, and also partial hepatobiliary phase hyperintensity, intensity. So remember, what I wanted to show is you will classically hear that hepatocellular carcinomas do not retain gadobenate. So up to 50% of HCC may retain gadobenate. The central fibrotic portion of any adenocarcinoma can be metastasis, can be cholangiocarcinoma, also retains gadobenate that gives a target appearance.
Yes.
This is not the this kind of nodule in nodule appearance. You just see a rim of hypo and inside there is contrast tertiary hepatobiliary phase. And lesions that classically retain hepatobiliary contrast. Do you know? Classical that retains hepatobiliary contrast and is diagnostic.
So, focal nodular hyperplasia.
Yes, and another one.
Well differentiated HCC.
That's I have already
And
discussed.
fibrolamellar HCC.
Not really. Another is dysplastic nodule. It can still retain contrast. So you have to be a little careful there.
Yes, sir.
But FNH is classically that something retains contrast. Okay.
Yes.
Okay, so let's go on to the next case. We don't have a lot of time now. So this is a 28-year-old lady with pain abdomen. So this is CT arterial phase and venous phase. What is there?
There is a well-defined lesion, arterial phase mildly enhancing and showing washout on venous phase, uh, seen in segment 4B of liver.
Yes.
It is mm,
Okay, that is correct. Arterial phase. I will call this a little bit of a hyper enhancement because it is enhancing more than the liver.
hmm.
So arterial phase enhancement, venous phase washout, segment 4B, well-defined nodule. No other findings. So this is the history. 28-year-old lady with some pain abdomen. So what can this be?
It can be a hepatic adenoma.
Yes. What else? Is it confirmed diagnosis? Anything else is possible? You are dealing with a arterial phase enhancing nodule that has washed out.
Could
Hepatic
be
adenoma, you have said.
hemangioma, but it is showing washout.
No, washout, you cannot say hemangioma.
Yes, sir. So
Adenoma, I agree.
hmm.
Anything else?
Hypervascular metastasis, if there is some primary.
Yes, good. It can also be an HCC.
Hmm. Also, it could be a primary NET of liver.
Yes, that is also true. So it can be NET, can be HCC, can be METS, can be adenoma. So we did an MR. Anything that is added?
It is
T2, phase
there,
T1, opposite phase T1, arterial phase, venous phase.
it is a T2 isointense lesion, but showing a drop on fat sat images, chemical shift image.
Right. So what does that indicate?
That it has intracellular fat, so that also is in favor of hepatic adenoma, more in favor of hepatic adenoma.
Yes. Hepatocellular carcinoma can also show macroscopic fat. This can, now you are saying, since it also has fat, and remember, this is not an at-risk liver.
Yes, sir.
This is a lady, young lady, who has this lesion. So here, hepatic adenoma becomes a distinct possibility. But do you need to biopsy this?
We can follow up the patient. If the lesion is increasing in size, then maybe we should biopsy.
Patient has only one lesion. Will you say, and it is 3 centimeter, 3.5 centimeter? You will tell the patient that follow up. Patient will listen.
Then we will biopsy, sir.
Patient will ask for a biopsy, and you should also biopsy ideally, because you said it can also be metastasis, right?
Yes, sir.
So you have to biopsy. You
Yes,
can't say that this is adenoma and we can follow up. Since metastasis is a possibility, NET is a possibility, you have to biopsy.
yes, sir.
So this was an adenoma. What I wanted to say is you can't apply RIRADS and say I can't do biopsy. You don't need to do biopsy. This is an arterially enhancing nodule which is washing out, like the earlier case. Okay, you have to do a biopsy because you cannot apply RIRADS. It is the most common tumor, hepatic tumor in young women on OCP. It will show arterial phase hyperenhancement and washout. Generally, in hepatobiliary phase, they are hypo, but sometimes they can retain contrast, but those are the bad kind of adenomas. Those adenomas are high risk of HCC. Okay. There is a classification of adenoma. There are 8 types. I'm not sure you need to remember all of them, but if you can remember for a short note, that's okay.
Yes, sir.
Okay, I think I will end with this one because there are questions that we may need to take. So I am pointing out to something. Can you see that these are all coronal vive post-contrast images? Can you see something, some abnormality? The arrows?
Mhm.
Any abnormality you can see? Some black area in the liver?
Yes, sir.
It is here seen also. See in the aorta, just here, some black area. What is that?
Um, osteoma.
Osteoma. There is no bone here, no? This, you are saying from osteoma from here,
Yes, sir.
like the Ziphi sternum.
Yes, sir.
And then over the aorta also, it has involved the aorta.
No, that being separate.
So that's a different lesion or same thing?
Fat, sir. Then
So you're saying that's fat that got suppressed.
yes,
Do you
sir.
want me to, do you want any other, any other images or anything? What do you suspect? What are you looking for? Suppose you see this, what will you do next? You realize this is fat suppressed image, right? That's a good observation that all the subcutaneous fat and retroperitoneal fat is suppressed. So this is fat suppressed. Since this is also black, this can be fat. That's a good observation. So what will you do?
Axial non-fat sat sequences, if available to see.
Okay. This is axial coronal sequences for you in T2. These are non-fat set.
So that was an artifact, sir.
Yeah. So do you know what artifact is this? So this is called a fat water swapping artifact that happens in Dixon images. So these were all Dixon post-contrast T1. So there will be a geographic area with very sharp margin. See how sharp the margin is?
Yes, sir.
This degree of sharpness does not come from any pathology. So this is an artifact that you have to keep in mind when you are looking at MRI. MRI has many weird artifacts. If you are unaware, there will be diagnostic issues. So this is just an artifact. This is called a fat water swapping artifact, occurs in Dixon MRI only, and it has sharp edges. It usually occurs at the ends of the FOV. That means the FOV is this entire thing that you see. So this is the end of the FOV. This area is the end of the FOV. From either end of the FOV, you will see, very commonly you will see this in spine where you take Dixon images. So remember this artifact, and if you repeat the study immediately, this artifact may disappear. Okay?
Yes, sir.
All right. So I will just try to go into questions. I see 76 chat. If there are questions, I will try to take. Okay. Melioidosis, yes, as I said, due to low immune infection, did you might include hydatid? I think this was the case that we were talking about. We talked about multilocularis. First case, a lot of people said hydatid. See, it can be hydatid. It can be a type 3 hydatid. But again, too many lesions, tiny lesions in spleen, and not really daughter cyst-like appearance. Okay. So once you know this can also be tuberculosis, it can be tuberculosis, it can definitely be melioidosis also. Splenic abscess, not infarct, true, deposit, ultrasound, can be splenic abscess, multiple nodule, lipomatosis, upper pole, that's not multicystic dysplasia. In the upper pole, as we discussed, lymphoma was a possibility, hepatomegaly, Beaver's lobe, I'm not really sure. Cholangitic abscess. Yes, cholangitic in a sense. Visceral lava migrans. Fasciola hepatica, somebody said, very good. Looks like La honeycombs. Eosinophil. So everybody really got the case. Hepatic adenoma, inflammatory type. That's very good. This one actually was HNF alpha type, but I can take it. Inflammatory is the most common type. I did not really have a good reason to say not. Nodule within nodule, HCC, cirrhosis, capsular reaction. What was the diagnosis? Adenoma. Okay, so what is the difference between renal replacement lipomatosis and xanthogranulomatosis pyelonephritis? That's a very good question. Renal replacement lipomatosis occurs as a response to chronic inflammation and irritation by the calculus. But if you do a biopsy, we'll just see fat. On the other hand, in xanthogranulomatosis pyelonephritis, which happens classically in diabetic patients with obstructed system, you will see xanthogranulomas, which are macrophages, who has eaten cholesterol. Xanthogranulomatous pyelonephritis is an inflammation, is an ongoing inflammation. Lipomatosis, on the other hand, is not, is just a response to chronic injury. Thank you. Yeah. Okay. Thank you, everyone. See you somewhere.